Good morning. We are here with Professor Amir LERMAN from the Mayo Clinic. You talked about the role of the microvascular dysfunction in patients with heart failure with preserved ejection fraction. Professor, I would like to ask you, are there any genetic or biochemical markers that can aid the clinicians identifying patients affected by heart failure with preserved ejection fraction and microvascular dysfunction? And if they might influence the development of tailor-made therapy for these patients?
Okay. Thanks for having me, and it's great to be here again. So, very good question about the genetic markers or any biomarkers in this disease. So, the concept of merging together the microvascular and heart failure with the preserved ejection fraction is relatively new. So, you need to look for markers that will identify both of them. For biomarkers, circulating biomarkers, we sometimes use BNP as a marker for both. We can see also some elevated of BNP specifically in female with microvascular disease and also with patient with heart failure with preserved ejection fraction. So BNP can give you some kind of an indication of the severity of disease or the presence of the disease. Another marker that we can use is troponin, even at rest. Troponin levels are known even without myocardial infarction to be a predictive of event, and they represent some myocardial injury. And patients with heart failure with preserved ejection fraction and microvascular disease sometimes have continuous myocardial injuries, specifically subendocardial, secondary to chronic ischemia from increased demand and low supply. So this is the biomarkers that I think we have for maybe emerge in this area. Genetic markers are not known to me, and you need to look for genetic markers that are specific for both of these entities. For microvascular dysfunction, there are currently no available biomarkers, genetic biomarkers, and similar to, there is a lot of them in hypertrophic cardiomyopathy and long QT. So they are more specific, but I hope that we will, when the area emerge, we will find more of this.
Okay, and I have just another question. If there are differences between patients affected by heart failure with preserved ejection fraction and comorbidities like hypertension, obesity, or characteristics like the female sex, and patients without comorbidities affected by heart failure with preserved ejection fraction?
Yeah. Another good question that is clinically relevant. I think that we found out that the presence of comorbidities like hypertension, obesity, it's more common in female, and other parameters like sleep apnea, or sometimes you see them as a group of symptoms together, so it is become a high risk patient with more comorbidity. So it is usually serving also in the background. By the way, all these factors that I mentioned, hypertension, metabolic syndrome and obesity, female sex, and sleep apnea are all also considered major risk factors for microvascular dysfunction. So they are a common ground for risk factors for both of them. So I think that we see comorbidity. We don't know, and we might know when we are now entering the area of SGLT2 inhibitors and GP1, that we can see effect on both hypertension, obesity, and microvascular dysfunction and heart failure preserved ejection fraction. So possible that these drugs that address in prediabetes, obesity, and metabolic syndrome will improve both of them, and that will help us also combat these risk factors. So I think, yes.
Thank you very much for the answer and for being here with us.
Thank you very much for the time. Thanks.